You are listening to the Your Knee, Your Health podcast. I'm your host, Adam Rosen. I'm a fellowship-trained, board-certified orthopedic surgeon who specializes in knee replacement. Here I'll talk to you about common knee complaints and other orthopedic issues. We'll cover other important health-related topics, all of which are meant to helpfully answer some of your questions and help improve the quality of your life. Thanks for listening, and on with the next episode. Hello, welcome back. This is Adam Rosen, and you're listening in to the Your Knee, Your Health podcast. So in today's episode, what I want to actually do is thank residents. It was actually Residents Week about a week ago, and a lot of times I find patients, they're not really sure. They don't really understand the difference between a medical student, an intern, a resident, a fellow. Like, what does that mean? What is their level of training? What can they do? What can't they do? Should you see someone that teaches residents? Should you not see someone? So I'm going to give you the inside scoop on what they are. And I'm going to tell you a lot of stuff that happens actually behind closed doors. So you have a good understanding. And I think most importantly, so you know what the right questions are to ask if you're being cared for by a doctor that teaches, young doctors or doctors in training. So let's talk about sort of the basic sequence, right? So you go to college, you get your 4-year undergraduate degree. Now, most people will do it in some form of a science like biology, because there are certain classes that you need to meet the criteria for applying to medical school, and most of them obviously are in the sciences. So you can get a major in anything. It just means that you have to take all the classes for your major plus all of the science classes and then sit for what's called your MCATs. It's kind of like your SATs for college, your MCATs for medical school. And after that whole application process, you get into medical school. And for most medical schools, the first 1 and 2 years of the 4-year program are classes. The classic gross anatomy, where you dissect a cadaver, a person that's given their body to science, and you take all the classes on pharmacology and physiology and anatomy and, the subspecialty things with cardiology, pulmonology, orthopedics, general surgery, urology. I mean, you name it, they go through all of that for 2 years. Now, most of the time, they'll start their clinical rotations in their 3rd and 4th year. So if you're in the hospital at a teaching institution, you may meet a medical student. So a medical student is not yet a doctor. They are usually a 3rd or 4th year medical student that is there to learn. So you may see them, and they may come in and ask you a lot of questions and take a history and examine you. And then they will report back to typically their resident. And then the resident, with the medical student, presents to the attending. And this whole thing starts the process of caring for you. Now, also, a lot of the unsung heroes are the nurses. The nurses, when I was a medical student and an intern and a resident, the nurses are great because they're there 8, 12 hours a day. The attendings may come and go. They may have other places, hospitals and offices to go. The nurses are the ones that go, "Are you sure you want to order this? I think you should order that." And when they tell you that, it's because they know what they're doing. They're not going to let you harm their patient. And they're also going to teach you at the same time. So the nurses are a huge part of the learning process for a lot of young doctors, interns, and residents, which is why I always tell the young people in training, like, be nice to the nurses. They're actually there to help you, and they're going to keep you out of trouble. So when you meet these people, sometimes I think the frustration is you explain your whole story to the medical student, and then lo and behold, they talk to the resident, and now the resident comes back, and guess what? They're going to ask you all the same questions. And that's where patients start to get a little frustrated, because then the resident goes to the attending and they present your case, and now the attending comes in, and guess what? He's going to ask you a whole lot of the same questions. And it is important because sometimes things are quite obvious, right? Like if you broke your leg and the bone's sticking out of the skin, there's not a whole lot. How'd you fall? How'd you injure it? What's your medical history? You need to have surgery. But when people come in with other diseases and symptoms, sometimes it's actually a good thing to be asked the same questions, because sometimes the medical student, the intern, the resident, the doctor may ask you similar questions, but in a different way. And sometimes you may actually answer in a different way. And that may actually help lead them to an appropriate diagnosis. But I always tell people, if you're really uncomfortable and you really don't like the process, you can say, "Listen, I really don't feel well. I really have a problem, or I have a place to go. I don't have time. I would love to just these are my basic symptoms. Can you just go talk to your attending resident, and then can we do this together? So you're the patient, and I think sometimes patients feel a little afraid to speak up sometimes in the healthcare institution. So definitely kind of step up and just let them know what you're feeling and how you're feeling. Um, Residents are there for a long time. So depending on the residency, it may be an extended period. So you've done your 4 years of medical school now, and then you have a year of internship, and then you have residency. So things like anesthesia, dermatology, emergency medicine, family practice, most of those are around 3 years. So now the doctor has done an additional 3 years of training. General surgery, orthopedics, urology, around 5 years. Neurosurgery, 7 years. So guess what? So most of these docs now are coming out with, most studies are showing $250,000 in debt because they've gone to undergrad and now they've gone to medical school and they've taken out loans to do so. And most of them are making $50,000, $60,000 a year. Most of them are working 80 hours a week and take off maybe 2 weeks for vacation, 50 weeks a year, 4,000 hours a year of work. And that's a lot, and then if you do like orthopedics and that's 5 years, it's, 20,000 hours, of work. So that's a lot. And they're there to learn. And guess what? Yep. You're one of the ways that they learn. They learn from talking and teaching and reviewing and x-rays and videos and books and journals, but at the end of the day, it's still an apprenticeship. So the residents and the fellows are there to learn. So what if you finish residency and now maybe you're going somewhere, like we work with fellows where I am, and you're meeting a fellow. What is a fellow? Okay, so a fellow is a doctor. So once you've graduated from medical school, you're a doctor. But you've completed your residency to be subspecialized in some specialty like orthopedics. And now you decide, maybe I want to do a subspecialty training year. So in orthopedics, you can do a fellowship in spine. You can do a fellowship in sports. You can do a fellowship in foot and ankle. You can do a fellowship in total joint replacement. So now you're meeting people that are in an additional year of training. So they've done their residency. They actually could go out and practice orthopedics and be a surgeon, but they've chosen to subspecialize in a particular niche. And the people that we work with, they work in total joint replacements. So at this point, you're wondering, well, do I go to a teaching hospital or do I not? Because there's always discussions and talks and there's some studies, yes, teaching hospitals have a higher complication rate. July is when these rotations for interns and residents start. The complication rate's higher. August is when fellows start. The complication rate's higher. And there's also been a lot of studies that have actually shown that's not true. And it's actually the opposite. So I always tell people, don't feel that you're getting second-class care by going to a teaching center. Again, there are people there that are overseeing all of these trainees. And sometimes I find that these training programs, have a very, very high level of expertise in some of these complicated things. Why? Because we're teaching people. So if you're teaching people, you're constantly on your toes. I find a lot of people that teach find that they're learning as much as they're teaching because, people that are learning are asking questions and you got to keep up with the times and you got to read. You'll meet some docs that are maybe really, really good. They've been doing it for 20 years at a community hospital and, they're doing it the same way they were taught 20 years ago in residency. They haven't been sort of up to date. People are sometimes saying, hey, I want to go somewhere where the newest and greatest technology is. Not that new and great technology is always the best. Sometimes we find out that new and improved really wasn't actually that much better once it's been out for a while. But your exposure to all of that stuff is on a regular basis because we're teaching people. So you may meet residents and you may meet fellows. Now, if your provider that you're going to see does work with residents and fellows, you want to ask some questions if you're not comfortable. So, how long has the resident or fellow been with you? Is this their first day? Is this their first week on the rotation? And that's a reasonable question to ask, because if someone's been there for 6 months or a year, that surgeon in training, that young doctor has worked with this attending for a while and they know their ins and outs and, they understand how things are done. If it's their first day, they're still learning the ropes. And then, you want to ask, well, are they there? Are they going to participate in my surgery and my procedure? Are they going to do things in the office like give injections? And they're all reasonable questions to ask. I think one of my mentors who said it best in our world, in our arena, which is total knee replacements, explained to people that, yes, I have residents there and we have an additional assistant or tech at the table. And basically, it's 6 hands plus the scrub tech. So 8 hands doing your operation. And it requires these 8 hands to complete the surgery well. And whether or not the resident's hands are on the cutting block or the retractors or your leg, and my hands are on the saw or the drill or putting the implant in, or vice versa. Maybe I'm holding the block and the resident has the saw. All of those things are being orchestrated the way that I want them done, the way that I feel is best for you and your care. So it's not as if someone's standing across the room and looking from afar, because that's, sometimes when mistakes can occur. But again, it still is a learning process. So I kind of tell people that, you don't want any residents and you think it's bad. Well, guess what? If a resident doesn't have an apprenticeship, or a fellow doesn't have an apprenticeship with somebody standing right next to them while they do these procedures, and then they go out and practice, guess what? That's even more dangerous, because there's nobody overseeing what they're doing. So it really is good to have this long training program, because they get to work with people side by side in real time to teach them and show them how to do things properly and how to do things well to prevent them from getting into trouble. Now, the other hard part is, is the attending there for the whole case, or are they there for just what's called the critical aspects of the case? So that's a reasonable question to ask. Ask the doctor, are you there for the whole thing? Are you there when I come in the room? Are you there when I wake up from anesthesia? Are you there just for portions of the surgery? Are you there when, they do the bone cuts, put the implants in? Are you there for the whole closure? Some doctors are there for the whole time. Some doctors are there for what they consider the critical aspects of the case. Do you run more than one room? And that's something that has come up from time to time. You've heard in the media, doctors running different rooms. And that's an important question to ask. If you have multiple trainees and you're running 2 or more rooms, the question that as a patient you want to know is, well, are you in my room for the whole case? And what if there's a complication? And, are you in the next room? Can you come back and forth and things like that? So that's, again, reasonable questions to ask. There are some hospitals, and you hear about these sometimes in the news, where, the trainees are doing surgeries with zero oversight. Doctor's not even in the hospital, or doctor's upstairs in his office. So, they're doing things without anybody being there. And there's other hospitals where the doc is always in the room for the whole thing. I can't tell you what's right and what's wrong. I can't tell you what's best and what's worst. I know for me, I'm always in the room from the beginning when the patient enters, because I'm helping set up the room, and I'm there till the last stitch is thrown and the patient's awakened from anesthesia and on the stretcher, because I find that's times where I can teach other things, not just the operation, but how to set the room up and how to put the dressings on, and making sure that all those things are taken care of. But they're all reasonable questions to ask. If you are going to see someone, you can see somebody in private practice. Understand that they don't have interns and residents and fellows. They probably still have other people working with them. So they have PAs, or what's called a physician assistant. Reasonable questions. Does your PA work with you in the operating room? How long have they been with you? Are you there for the whole case? Does the PA do anything by themselves? Some places have what's called RNFAs, registered nurse first assists. Some hospitals just have what's called OR scrub techs. What is the group doing? What are the people doing? What are the responsibilities of all of those parties? Because each of those people are an extension of your doctor. They're an extension of your surgeon. At the end of the day, it is the surgeon's responsibility. It is the captain of the ship. It is the one that is responsible for all parties involved, including both the patient and all the other people that are involved in that patient's care. So you just want to make sure that, your doctor is aligned with your thoughts and your wishes, and you understand, what their responsibilities are and when they're there and when they're not there. Because at the end of the day, the goal is to take care of you, the patient. But also at the end of the day is to train doctors, because in the future, we need more doctors. As the older doctors retire, the newer doctors are going to take care. And you don't want the doctor coming in without any experience in what they're doing. So this is stuff that I'm not sure many people want to talk about and want to share, but it's the reality. And, like you've heard on some of my other talks, I am very upfront and I am very honest. I will tell you what it is and how it is. And I like to share that information with you, because I want you and I like my patients to be informed. But sometimes people don't know what the questions are that they're supposed to ask. So hopefully I've shared with you some questions that you may ask. if you're seeing a doctor, if you're going to a hospital, if you're going to have surgery, and if you're in a teaching hospital or a non-teaching hospital, what are some of the questions that you want to ask just to make sure that you get the best care that you can possibly get. So in the meantime, stay safe. If you enjoy what you're hearing, please share this with your friends. If you have the time, please leave a review. It's reviews like yours that help other people like you find this podcast. And if you haven't already, please subscribe. This way you'll keep updated and get downloads of all the newest episodes once they come out. Until next time, I'm Adam Rosen, and thanks. You've been listening to the Your Knee, Your Health podcast. Thanks for listening to the Your Knee, Your Health podcast. If you've not already done so, please subscribe so you'll be notified of future episodes. And if you enjoy what you're hearing, please take the time to leave a review. It helps other people like you find the show. I'm your host, Adam Rosen, and until next time, stay safe.